وهي ديت أول حالة. and this is as you can see, this is testicular Doppler ultrasound. عاوزين we'd like to know what is this area and what is the pathology. Okay, and this is the epididymis. As you know, this is the site of the testicle, and this is the epididymis. And you can easily appreciate the presence of marked Doppler flow in the epididymis, which means that there is some sort of an inflammation, and this is characteristic of epididymitis, which can occur as an isolated lesion or can be associated with inflammation of the testicle. And at that time, you can also see a Doppler flow in the involved testis, and the diagnosis will be epididymoorchitis. The next case is a post-contrast CT scan obtained from the pelvis of a patient complaining of hematuria. Okay, I didn't receive any answer. Then what is you looking for? This is the urinary bladder, and this is the big vesical diverticulum that is connected to the bladder via a broad neck. And in the diverticulum, you can see an enhancing soft tissue mass, which is diagnostic of carcinoma, urethral carcinoma, that has occurred in a urinary bladder diverticulum, which is a common finding in the clinical practice. Next case is an MR urogram of the kidneys, ureters, and the urinary bladder. Still no answers coming on the chat, and if you look carefully on the MR urogram, you can see no, this is not a retroperitoneal fibrosis. It occurs relatively lower down in this particular area, but if you look carefully, you see the abnormal course of the right ureter, which is very close to the midline, with consequent considerable dilatation of the pelvic ileal system in a case of a retrocaval ureter. The next case is CT scan with contrast of the region of the kidneys, showing a lesion in the left kidney, and this is the coronal scan for the same area. Okay, and you can see here that the pelvic ileal system is occupied by an enhancing soft tissue mass, which is occupying the renal pelvis as well as the calyces. And this is transitional cell carcinoma of the renal pelvis and the calyces, which is different from the renal cell carcinoma that is occurs in the renal parenchyma, not inside the collecting system. The next case is the patient with a history of right partial nephrectomy, and at the operative bed, you can see this appearance. Yes, the answer is right. And you can see that there is a collection at the operative bed. This is the remaining part of the kidney, and the collection contains the air fluid level with an enhancing margin and the stranding of the surrounding fat, diagnostic of an operative bed abscess. Next case is an ultrasound of the testis in a patient who known to have a small cell lung carcinoma. Yes, and this is testicular metastasis. You can see multiple hypoechoic lesions within the testis. And in a case that you know that there is a primary, known primary malignancy, and you should consider that these lesions belong to the primary lesion, and these were renal or sorry, testicular metastatic deposits from the lung cancer. Next case is pre-contrast and post-contrast scans of the region of the left kidney. Okay, and there is a solid mass in the lower bowl of the kidney, and this mass is almost homogeneously enhancing. And you know that any solid mass in the kidney in an adult should be considered as renal cell carcinoma until proved otherwise. And any solid mass in the kidney of an adult patient should be considered as renal cell carcinoma until proved otherwise, exactly similar to a solid mass in the lung of an adult should be considered as bronchogenic carcinoma until proved otherwise. And this is a case of MRI of the kidney showing a small lesion in the left kidney. And this is the appearance of the lesion in the T1 and T1 fat set. And this is the out of phase image. And this is T2 weighted images. Yes, and this is a very small angiomyolipoma of the kidney. The lesion contains fat. It is bright. in the T1 and suppressed in the fat suppressed images, denoting the presence of fat. And there are a lot of lesions containing fat in the kidney, but the most common by far is the angiomyolipoma. Lipoma of the kidney is very rare. Liposarcoma is also rare. Dermoid cyst of the kidney is rare. And xanthogranulomatous pyelonephritis has a very well-known characteristic appearance. But then if you see a fat-containing lesion in the kidney, you should think first of an angiomyolipoma. And this is not a hemorrhagic cyst because it is suppressed in the fat suppressed images, denoting the content of fat. And this is angiomyolipoma. The next case is an ultrasound of the testis. This is ultrasound and this is Doppler. The patient had a recent history of trauma to the scrotum. And it is not subcapsular, it is a testicular hematoma. Considering the history of trauma and you got a well-defined lesion within the testicular tissue and there is absence of Doppler flow within this lesion, denoting that it is a hematoma, and this is hematoma inside the testis. The next case is a post-contrast CT scan of the abdomen in the region of the kidneys. Yes, and this is renal cell carcinoma. What do you think about this? Yes, metastatic lymph node, right answer. And this is a solid mass in the left kidney, diagnostic of renal cell carcinoma, and this is para-aortic mass representing metastatic lymph node, and this is a simple cyst in the opposite kidney. Then the next case is a patient with a recent history of blunt abdominal trauma. This is post-contrast axial and coronal images. Infarcted kidney due to trauma, subcapsular hematoma in the kidney. Actually, you know, whenever there is an abdominal trauma and you got a kidney that is enhanced and another one that is not excreting contrast material, then you are dealing with avulsion of the renal vascular pedicle. There is no blood supply coming to this kidney, and this was confirmed by angiography. You see that the renal artery has been interrupted in this area, diagnostic of avulsion of the renal vascular pedicle. Next case is a CT scan of the abdomen at the level of the kidney and another one at the level of the urinary bladder. Okay, in this section, and you can see there is an ill-defined soft tissue mass, and this is originating from the posterior wall of the urinary bladder and has extended outside the bladder, invading the seminal vesicle and most likely invading the ureteric orifice as well. And this is the cause of back pressure effect on the left kidney. The diagnosis is urethral tumor or bladder cancer with extravesical extension and proximal back pressure effect. The next case is um, a coronal CT urography and another coronal CT reformatted image of the renal area showing a large lower ball left renal lesion. Okay, of course, this is not a simple renal cyst. It is atypical renal cyst, and it shows some enhancing mural nodules, especially in its inferior part. And the presence of mural nodules in cystic lesion indicates that this is carcinoma, and that diagnosis will be cystic renal cell carcinoma. Next case is a CT scan after contrast in the region of the aorta and iliac arteries. Yes, and the answer is right. This is retroperitoneal fibrosis. There is a big soft tissue density surrounding the aorta as well as the iliac vessels, diagnostic of retroperitoneal fibrosis. In this case, the patient had painless hard mass and his serum BHCG والalpha fetoprotein والLDH were normal. His age is 22 years old and the lesion is devoid of vascularity on Doppler imaging. This very characteristic whorly appearance of a testicular lesion that is not vascular and does not cause any symptoms is very characteristic for testicular epidermoid cyst. Next case is a child with two films, one during the ascending cystography phase and another one during or after micturition. Okay, and if you see that the contrast material has passed through the ureter to the collecting system during ascending cystography, and this is vesiculoreteric reflux grade 5, because the ureter is dilated and tortuous, the pelvic cell system is ballooned. And after micturition, you got persistence of the dilated pelvic cell system with normal caliber of the ureter, denoting the presence of pelvic-ureteric junction obstruction. And the patient had the two lesions. He has vesiculoreteric reflux grade 5 and congenital pelvic-ureteric junction obstruction. Next case is a CT scan of the abdomen showing this lesion in the retroperitoneal area. Okay, if you look carefully here, you see that this is the left kidney, which is enlarged and mostly replaced by fat, with a big radiopaque stone in the renal pelvis, and densogranulomatous pyelonephritis is a good answer, but you should mention that the inflammation has extended into the perinephric, paranephric, and in the posterior abdominal wall in the form of multilocular abscesses. The answer is xanthogranulomatous pyelonephritis that has progressed to a perinephric abscess that has involved the posterior abdominal wall as well. Next case is an ultrasound of the testis. And this is a simple cyst, and the test is showing all the criteria of simple cyst anywhere in the body, with acoustic enhancement and hypoechoic or anechoic content, very thin paper, thin wall, and no internal septations, no calcifications, and no mural nodules. And the testis can show. So this is not testicular microlithiasis. This is simple testicular cyst. The next case is abdominal scans. And these scans are obtained without injection of contrast material. Yes, and the answer is right. This is TB of the kidney, TB of the spleen, and the TB of the liver. And this kidney is known as end-stage kidney or butty kidney, which is totally calcified and is out of function, sometimes known as TB autonephrectomy. Next case is a female infant, 4 months old, with this is ascending cystourethropy. This is female. And posterior urethral valve does not occur in females. This is vesico-ureteric reflux because of the ectopic insertion of the ureter in the urethra. And this is the bladder, this is the ureter, and it inserts into the bladder neck or in the proximal part of the urethra with grade 5 vesico-ureteric reflux. Ectopic ureter with grade 5 vesico-ureteric reflux. Non-contrast CT scans of the kidneys and urinary bladder as well. Yes, the diagnosis is easy in this case because you see air in the kidney, air in the urinary bladder, and you got some calcification or stones. It does not make a big difference. The diagnosis is emphysematous pyelonephritis and emphysematous cystitis, and these emphysematous changes are common in diabetic patients, as I have mentioned before. Next case is a CT scan, axial and coronal reformatted images of the kidneys. Yes, the answer is right, and this is bilateral chronic pyelonephritic kidneys. You see marked loss of the renal parenchyma with scar tissue that has resulted in this appearance. The calyx is not covered by any renal parenchymal tissue, and this is the case also on the right side. The diagnosis is bilateral chronic pyelonephritis. This case, you see an axial CT without contrast, with contrast, coronal reformatted images with contrast. The appearance in the pre-contrast scans is difficult to be diagnosed, but after injection of contrast material, you got multiple marginally enhancing lesions in the kidney as well as in the liver, and these are abscesses affecting the kidney and extended into the perinephric space and also extended into the liver parenchyma, resulting in another abscess. Multilocular nephroma is a single cyst and it contains some internal septations, but this is definitely an inflammatory lesion. This is renal abscess with hepatic extension. In this case, you see a lesion in the region of the left kidney, in this MR T2 weighted images with fat set. I think the diagnosis is very easy in this case because you see the typical features of renal hydatid cyst. You got multiple cysts with internal daughter cysts, which are classic appearance of the hydatid cyst in the kidney. And this is the gross specimen after surgical removal. And you see the big lesion with internal daughter cysts inside corresponding to this MR images. MR image. Um, this is actually an ascending and a descending cystourethropy. Contrast has been injected through the urethra and through a suprapubic cystostomy as well. Yes, and this is urethral stricture, very tight urethral stricture in the benign part of the urethra with attenuation of the rest of the benign urethra and marked distension of the prostatic urethra, the membranous urethra, as well as the bulbar urethra. The next case is a CT scan post-contrast for the region of the kidneys. Okay, you see that the left kidney is not functioning well, and there is no, this is not a renal cystic renal cell carcinoma. You got a renal cyst with foci of marginal calcification, maybe in the wall of the cyst as well as in the renal parenchyma. And you remember that I have said that whenever you see calcium in the renal parenchyma with no evidence of masses or tumors, then you think of TB. And this is one of the appearances of renal tuberculosis with foci of matrix calcification and relatively poor function of the left kidney compared to the right one. Testicular ultrasound showing a classic feature which I think is commonly seen in the clinical practice. Okay, these bright foci seen scattered through the testicle is diagnostic of testicular microlithiasis, and this is right. Here is an ascending cystourethropy and of the child, as you can see, showing the disappearance of the urinary bladder as well as the kidney. Okay, the answer has been shown. This is a neurogenic bladder. You see the marked trabeculation and thickening of the wall with diverticular outpouching, and consequently you got grade 5 vesico-ureteric reflux, or maybe grade 4, because the ureter is not that tortuous. Grade 4 vesico-ureteric reflux. The next case is a series of CT scans after contrast injection for the lower abdomen and the pelvis. Herniation into the inguinal region. This is right. If you look carefully here, and anytime you see that the bladder is pointing to the inguinal canal, then you should continue. Then you see that part of the urinary bladder is herniating through the inguinal canal to the scrotum. And this is herniation of the urinary bladder, or this is an inguinal hernia containing part of the urinary bladder. This appearance is very frequent in the examinations. The next case is an X-ray with cystography and CT scan of the pelvis of the same case. No, this is intraperitoneal rupture of the urinary bladder, because the contrast material is present within the peritoneal cavity surrounding the bowel loops. And you can see this fracture, which is indicating that the patient has been subjected to a kind of trauma, and this trauma has ruptured the urinary bladder. If the urinary bladder ruptured extraperitoneally, and you see the contrast material in the pelvic floor muscles and soft tissues. But if you see the contrast material surrounding the bowel loops, then this is an intraperitoneal rupture of the urinary bladder. Next case is a 15-minute film obtained from an intravenous urography study. Ectopic pelvic left kidney, this is right. You see that the left kidney is at the level of the sacrum, and the ureter is short, because the kidney is ectopic in the pelvis, and the right kidney is good. This is ectopic left kidney. Next case is an ascending urethrophy. Um, uh, Posterior urethral stricture, yes, and this is right. This type of fixation indicates that this is an open book fracture of the pelvis, and you got marked narrowing of the posterior urethra, and also you got some narrowing here in the bulbar urethra as well. Then the trauma may result in urethral rupture or urethral stricture, and the urethral stricture can be single and can be multiple sometimes. This is a female patient, 37 years old, with, and you can see here that the right kidney is markedly hydronephrotic. And in these films, you can see the cause. Sometimes, if you cannot see cause of obstruction, you can look for the left ureter. If the ureter is of normal caliber, you think of pelvic-ureteric junction obstruction. But in this case, and you can see this is the pelvic-ureteric junction. A little bit lower down, you can see a radiopaque stone. This is the site of the stone obstructing the proximal part of the ureter with consequent marked dilatation of the renal pelvis and the calyces. The next case is a female 73 years old with hematuria, ultrasound and CT and arterial phase and excretory phase. Yes, and this is transitional cell carcinoma in the renal pelvis, which is seen here by ultrasound and also seen here as a filling defect within the renal pelvis, especially noted in the excretory phase. Then why this is not a radiolucent stone? Because in the ultrasound you do not see the acoustic shadowing of the stone. Why this is not a blood clot? Because in the ultrasound you know that blood clots are echogenic. Then the diagnosis is transitional cell carcinoma of the renal pelvis. And here, two scans of the kidneys without contrast. In this case, it's seen every day in the radiology practice, CT, UT, with bilateral renal stones. The stone on the left side is a staghorn calculus that is filling the renal pelvis and the proximal part of the ureter as well as the calyces. On the left side, and you can see multiple renal stones with considerable distension of the renal valves. This distension is due to maybe due to ureteric stone, or maybe due to pelvic-ureteric junction obstruction, and you should see the remaining part of the exam to differentiate between both. Next case is male, 53 years old, with ultrasound of the kidney, CT without contrast, and CT with contrast excretory phase. Yes, and the answer is right. This is parapelvic renal cyst. It has the typical cyst criteria in ultrasound, and the after contrast injection, you do not see any contrast material within the lesion, denoting that it is extracalyceal, meaning that it is a renal sinus cyst or a parapelvic cyst. This patient is diabetic, and you can see the scans of the kidney obtained after contrast injection. And whenever you are told that the patient is diabetic, and you think of infection, and the infection here is bilateral. It is not xanthogranulomatous pyelonephritis, but these are multiple abscesses in the renal parenchyma and perinephric space, with extension to the collecting system. The xanthogranulomatous pyelonephritis is usually unilateral pathology, and the kidney is not functioning. The kidney is enlarged, and most of the kidney may be replaced by fat, and there should be a big stone in the renal pelvis. These are missing here. These criteria of xanthogranulomatous pyelonephritis are not seen in this case, but the right answer is bilateral renal, nephric, and perinephric abscesses involving as well the collecting system. This is a selected film from an intravenous urograph. And he said that there is some stasis in the ureters, and I am not sure if the intravenous urography studies are seen frequently in the exams or not, but this examination is considered one of the basics of urinary tract imaging. If you look carefully here, you see a filling defect in the renal pelvis. And if you look carefully here, and you can see another filling defect in the distal part of the ureter. And filling defects are usually interpreted as calculi unless proved otherwise. But if you have a better look for this appearance, it is not a calculus, it is not surrounded by contrast material, then you consider a mural filling defect, which means that you are dealing with a urethral tumor. And you know that urethral tumors can occur multifocal, and this is the case where you can see a tumor in the right renal pelvis and a tumor in the distal part of the left ureter, and very frequently you can see another one in the urinary bladder, but in this case, no. Then this is the magnification of this area, and you can see the filling defect in there. If this is a radiolucent stone, it should be surrounded by contrast from all aspects. If you see that contrast is missing along one of the borders, forget about the stone, and this is a mural lesion. The same is applied for polyps in the colon, because the pedunculated polyp is surrounded by contrast from all directions, but the sessile polyp, which is most likely malignant, is not surrounded by contrast material. Okay, this is an ascending urethrography, and you can see an abnormal appearance. Instead of opacifying the urinary bladder, you got opacification of the colon. Posterior urethral injury, and then if the urethra is injured, you got extravasation of contrast material at the site of injury. But if you see that the urethral outline is continuous, but it ended in the colon instead of the urinary bladder, you may think of a urethrocholic fistula. And whatever the cause of this fistula, if it is secondary to instrumentation or some sort of surgery or endoscopy or trauma, direct trauma, but the diagnosis in such cases is the presence of free communication between the urethra and rectum, which is diagnostic of urethrorectal fistula. This is a male patient, 79 years old, and he has loose stools with raised inflammatory markers, vast medical history of multiple urinary tract infections. And this is MRI and CT of the prostate, CT axial, CT coronal, axial T2, coronal T2, axial diffusion, and ADC. Someone is asking why the previous case is not some sort of diversion. Actually, there is no known diversion of the urethra to the rectum, and the opposite. Nothing is known in the medical practice like this. Diversion of the urinary pathway may be to the colon. The ureters are implanted to the colon, and this is a direct communication between the urethra and the rectum. I don't know the underlying exact etiology, but if you are confronted with a case similar to this, And if you asked about the clinical data of the patient and they said answer as such, no medical history, as frequently happens in our exams, then you have to say that this is a communication between the urethra and the rectum indicating recto-urethral fistula. Then what do you think about this case? The previous case, how we know that this is bowel? What else? This is not the urinary bladder, of course, and this is, you look to the configuration, this is the anatomic site, the mucosal pattern, and the wall of the rectum. Okay, then let us see what is the answer for this case. Okay, and this is a straightforward case of a prostatic abscess. If you look here and you see a collection that is marginally enhancing in the axial and the coronal images, and the abscess is bright, and the T2 weighted images and the contents will show marked diffusion restriction. This is not a prostatic cancer because the prostatic cancer is black or of low signal in the T2 weighted images. And the prostatic cancer does not look like fluid in the CT images. The answer is a prostatic abscess. Thank you very much ونراكم على خير إن شاء الله.